One of the most important diseases in the lower respiratory tract is that caused by mycobacteria. So, to conclude the discussion of lower respiratory tract infections, we will review the characteristics of mycobacterial species. We will also discuss the pathogenesis of tuberculosis, how this infection is acquired, and who the susceptible patients are. After reading the opening case study, take a few minutes to review the points to consider listed here. Also consider these points as you go through the lesson and your readings. So this is a case about a 56-year-old man who came to the emergency room with complaints of fatigue and weight loss. He had a history of cough for 3 months that produced sputum tinged with blood. He also had a fever and night sweats. X-ray examination revealed infiltrate in the right upper lobe. Sputum samples were collected and set up for acid-fast bacillus, AFB smears, and culture. The AFB smears yielded negative results. BACTEC 12B bottles, that's an automated blood culture system, produced growth after 12 to 14 days of acid-fast bacilli later identified as tuberculosis, Mycobacterium tuberculosis. Here are points to consider as you go through the lesson. Why is it important to determine the patient history and clinical symptoms? What are the risk factors that predispose this patient and individuals to mycobacterial infections? Which segments of the population are at high risk of mycobacterial infections? Why is a direct smear examination significant, even when it produces negative findings? What does it mean? And consider other points also as you go through the lesson. Tuberculosis, or we call it TB, is a disease that has afflicted mankind in epidemic proportions during the 18th and 19th century. Once thought to be a disease of the past, TB has all but faded from the American healthcare system. In the early 1980s, tuberculosis reemerged, and the fear of widespread dissemination of TB to other patients, healthcare practitioners, and the community at large materialized in the early 1990s at the height of the TB epidemic in this country. TB facilities that had been closed for decades were reopened, and patients were quarantined in public institutions to warrant compliance of therapy and prevent further spread of the disease, especially in the immune-suppressed populations. Although TB treatment, which was introduced in the late 1940s, and tuberculosis declined in the Western countries, tuberculosis has remained the leading cause of death due to an infectious disease worldwide. Infection rate of tuberculosis in the third world country is estimated at near 50%, and in the world as a whole at 33%. In people living with HIV/AIDS, mycobacterial infections remain a major morbidity and mortality. While over 90% of tuberculosis cases can be cured by the standard treatment methods, multi-drug resistant strains of Mycobacterium tuberculosis have been isolated. So let's start talking about the pathogenesis of tuberculosis. The agent of tuberculosis is Mycobacterium tuberculosis. We know that, also known as tubercle bacilli. Tuberculosis is primarily spread by airborne transmission through droplet spray, or what we also call as droplet nuclei. This occurs when an infected, untreated person coughs, sneezes, speaks. The tubercle bacilli present in the lungs are dispersed in the air. Close contacts are at high risk, with an infection rate of 29% of acquiring the infection. However, only 10% of infected persons will develop the clinical disease at one point in their lifetime. There are numerous predisposing factors that increase the risk of individuals to acquiring the infection. Although all sectors of the society are at risk, there are certain predisposing factors that have remained the same over the centuries. These include economic depression and war, ignorance, poverty, and overcrowding, poor hygiene, and related low socioeconomic conditions. The poor are the usual victims. Today, the populations at risk include persons with HIV, close contact with persons who have TB in households or in homeless shelters, foreign-born individuals, particularly those from Asia, Africa, and Latin America, those who live in convalescent homes, nursing homes, and prisons. Blacks, Hispanics, and Native Americans are at higher risk than Caucasians. The disease continues to be seen in children, especially in ages ranging from newborn to 5 years old. The primary infection results from the initial exposure of an individual not previously been sensitized by the tubercle bacilli. As the tubercle bacillus is inhaled, the patient may experience just a flu-like pulmonary syndrome. In rare occasions, a complete resolution occurs. More likely, however, the tubercle bacilli, upon reaching the pulmonary alveoli, are engulfed by macrophages and are carried to the hilar lymph nodes. Hypersensitivity and cell-mediated immunity develop between 2 to 10 weeks after exposure and infection. As cell-mediated immunity continues to develop, granulomas begin to form, the lesion heals, fibrose, and calcify. The tissues die, but the organisms may have survived intracellular killing and remain stable for many years. In this image here, you're looking at tubercle bacilli engulfed inside macrophages. Here is a schematic representation of the stages in primary tubercular infection. Once inhaled, Mycobacterium tuberculosis cells are phagocytized by alveolar macrophages. As mentioned previously, there is no subsequent infection in rare occasions. Because of the pathologic features of TB are the result of a hypersensitivity reaction to mycobacterial antigen, in many exposed individuals, the immune system does not initially eliminate the bacteria. If there is little antigen and a strong hypersensitivity reaction, a hard tubercle or granuloma might be formed. The granuloma is an organization of lymphocytes, macrophages, fibroblasts, and capillaries along with fibrosis and encapsulation. With granuloma formation, the bacteria can ultimately be killed and healing occurs, as well as calcification with scar formation as a reminder of the past infection. The patient, nevertheless, will produce a positive skin test. A small percentage of individuals, however, who are infected with tuberculosis develop progressive or active pulmonary disease, usually from a failed cellular immune response and hence a failure to stop multiplication of the bacilli. In young children or older adults who are primarily infected, and in people with an underlying immunodeficiency, massive lymphohematogenous dissemination may occur and lead to meningeal or miliary, that is, disseminated form of tuberculosis. Progression from infection to active disease varies with age and the intensity and duration of exposure. Malnutrition, with or without factors such as alcoholism, homelessness, incarceration, immunosuppression, and acquired immunodeficiency syndrome or AIDS can contribute greatly to the progression to active TB. Now, reactivation occurs usually later on in life, associated predominantly with the elderly and with factors such as malnutrition, alcoholism, diabetes, and even stress. Breakdown of the calcified granulomas lead to the clinical disease. Progression that leads to dissemination or miliary tuberculosis is most likely to occur in the immune-suppressed, that is AIDS patients, and in young children. So again here, referring to the schema, the risk of reactivation of tuberculosis is about 3.3% during the first year after a positive skin test, and a total of 5% to 15% thereafter in the person's lifetime. Reactivation tuberculosis occurs when there is an alteration or suppression of the cellular immune system in the infected host that favors replication of the bacilli and progression to the disease. Clinical evaluation consists of evaluating the symptoms that include blood-tinged sputum produced from cough or prolonged duration. This occurs when small blood vessels erode when necrotic material is discharged. Additional hallmarks of the disease include fever, night sweats, and weight loss. X-rays will reveal consolidation in the affected area of the lungs. Interpretation of the tuberculin test will vary dependent on the patient population involved. It will be unlikely that you will be asked to interpret a tuberculin test. So the information that you have here is for your information only. Let us review the laboratory diagnosis of mycobacterial species. The increase in cases of tuberculosis in the United States associated with AIDS epidemic, particularly in the 90s and the early 2000s, and the emergence of the multi-drug resistant tubercle bacilli required rapid and accurate laboratory methods to recover and identify Mycobacterium tuberculosis. So here are the general characteristics of Mycobacteria as a review. The genus Mycobacterium includes species that are non-motile, non-spore-forming, gram-positive bacilli. The cell wall of Mycobacterium species, as you recall, has high lipid content or mycolic acid, and therefore receives staining the gram stain. Microscopy is performed using special stains such as Ziehl-Neelsen or Kenyon's acid-fast stains. Although some are saprophytes, certain species are definite pathogens. Members of the genus need complex nutritional growth requirements, but will grow in artificial media except for Mycobacterium leprae. So do review the classification of Mycobacterium species according to their photoreactivity. That is most helpful in the initial identification of a Mycobacteria isolate. Other characteristics such as rate of growth, optimum growth temperature, and colony morphology would also provide guidance in the selection of additional biochemical tests for definitive identification. So make sure that you are able to define and characterize species that are photochromogenic, scotochromogenic, and non-chromogenic. Remember that recovery rate for Mycobacteria ranges from 3 days to 60 days. So record the rate of growth. Those that appear or produce colonies in less than 7 days are considered rapid growers. That may be one, as I mentioned, of the characteristics that you may want to consider rate of growth in your identification schema. And lastly, the optimum temperature of certain species varies. Some species grow best at 30 to 32 degrees centigrade, while others may prefer 42 degrees centigrade. These are the different acceptable specimens that you may receive for processing for mycobacterial culture. Respiratory specimens may include expectorated sputum, nebulized induced sputum, transtracheal aspirate, bronchoalveolar lavage, and laryngeal swab may be submitted for culture. Body fluids may include pleural fluid, pericardial fluid, joint aspirate, gastric aspirate, peritoneal fluid, cerebrospinal fluid, stools, urine, and pus may also be submitted for mycobacterial culture. Body tissues, such as blood, bone marrow, biopsy and aspirate, solid organ, lymph node, bone, and skin are also acceptable specimens for processing and will be requested for mycobacterium culture. Samples such as urine and sputum contain organisms other than mycobacteria. Most of these organisms multiply and grow faster than mycobacteria and may tend to overgrow these organisms. It is therefore necessary to treat most specimens with chemical agents that not only kill most contaminating organisms, but also liquefy the sample, especially sputum samples. Do remember that body fluids that are normally sterile and collected from sterile sites may not need digestion and decontamination procedures. But urine and sputum in particular will require this particular uh, laboratory procedure. So as a review, the purpose and use of chemical agents in decontamination and digestion procedures. Sodium hydroxide, different percentage, serves as a decontaminating agent and also a digestant. And acetyl L-cysteine serves as a liquefying or mucolytic agent. This is particularly required for sputum samples. Some laboratories may prefer benzalkonium chloride or Zephyrin with trisodium phosphate. ZTSP liquefies sputum rapidly, but requires long exposure to decontaminating agent. And Zephyrin in combination is bacteriostatic to tubercle bacilli. When you receive specimens in routine culture produce Pseudomonas aeruginosa, samples requested for Mycobacterium culture needs to be treated with oxalic acid, about 5%. The examination of stain smears is the most rapid procedure available to the microbiologist for the detection of acid-fast bacilli. The sensitivity of the stain smear is dependent on the number of organisms present, and it needs about 10,000 to 100,000 AFD per ml of sputum, and of course the method used for staining and microscopy. So you must take note of the following. AFB on stain smear does not speciate mycobacteria. Speciation is only done in culture. Negative smear does not rule out tuberculosis or other mycobacterial infections. However, you must not underestimate the value of microscopy. Patients with positive sputum smears are the greatest threat to the community. In the previous slide, you saw an abscess aspirate smeared stained with gram stain. Mycobacterium species show as gram-positive bacilli, beaded and hardly visible in a gram stain. The same abscess aspirate smear at the bottom image in the previous slide shows acid-fast bacilli stained with Ziehl-Neelsen, which is an acid-fast stain. The culture grew, as noted, as Mycobacterium cansaceae. Here you are seeing another way to visualize Mycobacterium organisms, and that is using a fluorochrome acid-fast stain. And here is an expectorated sputum smear. The culture grew Mycobacterium tuberculosis. The bottom right image shows Mycobacterium leprae from skin biopsy stained with Ziehl-Neelsen from a patient with Leprematous leprosy. This particular case I encountered when I was in Texas. So just as a reminder that Mycobacterium leprae does not grow on artificial media. So the definitive diagnosis requires isolation and of the organisms in culture, as we already mentioned previously. So review the different selective and non-selective culture media used for mycobacterial isolation. Incubate cultures at 35 to 37 degrees in 5 to 10% CO2, except for certain types of clinical samples where a 30 to 32 degrees may be necessary as a second set of cultures to recover the suspected species. Cultures must be observed after incubation for 5 to 7 days to detect rapidly growing mycobacterium, and other contaminants. You need to examine cultures weekly for 6 to 8 weeks before reporting the culture as negative. Once colonies appear on the culture media, they should be examined by acid-fast stain to ensure that they are indeed acid-fast bacillus. You have to be able to, at the minimum, presumptively identify or differentiate Mycobacterium tuberculosis from other mycobacteria. So again, use a minimum criteria such as rate of growth. Did it grow in less than 7 days, or did it grow in 10 or more days? Is there a pigment? What is a photoreactivity? And the limited biochemical test for presumptive identification. Niacin test, catalase at 68 degrees centigrade, nitrate reduction are most useful. So refer to your textbook chapter for identification of important Mycobacterium species. There are numerous identification methods in addition to conventional tests that are used to speciate and identify Mycobacterium species. HPLC, or high performance liquid chromatography, for example, utilizes the principle of species-specific fatty acids for identification. Mycobacterial species vary in composition of mycolic acids present in their cell wall. Mycolic acids are therefore extracted and ran through the HPLC system. A characteristic chromatogram is derived and compared through a database with known standards. DNA probes use nucleic acid hybridization with specific labeled sequences to detect the corresponding sequences in the unknown. This technique is 100% sensitive and specific when used to identify from cultures. PCR, or polymerase chain reaction assays, are based on the amplification of a DNA sequence coding for antigens specific for mycobacteria. Once a PCR replicates enough DNA target material, DNA probes are used to detect the amplified sequence. So, as we mentioned before, in the identification of Mycobacterium species, photoreactivity is a good criteria to start differentiating your pathogenic Mycobacterium species from others. One way is to see if the organism is growing in culture is non-chromogenic, is a non-chromogen, and non-photoreactive. Now, Mycobacterium tuberculosis is characteristically non-chromogenic and non-photoreactive. It is also positive for niacin accumulation and reduction of nitrate to nitrite. Production of catalase is destroyed after heating, so it is heat-stable catalase, negative. So this is what a non-chromogenic or non-chromogen Mycobacterium colony looks like. So Mycobacterium scrophulaceum is a good example of a scotochromogenic. So again, review the definition of what is a schromogenic species. Mycobacterium cansaceae is a good example showing photoreactivity or photochromogen. So again, review the definition and characterization of a photochromogen. Let me spend a few minutes to talk about antitubercular therapy. Streptomycin is one of the first anti-tubercular agents introduced in the 1940s. It is mycobactericidal because it inhibits protein synthesis and was found to be most effective against actively replicating cells. Within months of introduction, most patient isolates developed resistance to the drug. In 1946, PAS, or para-aminosalicylic acid, was found to decrease this resistance when given with streptomycin. So in 1952, a regimen of INH, or isoniazid, PAS, and streptomycin given for 2 years resulted in clinical cure. So it was apparent that combination therapy would become the protocol for treating tuberculosis. It is important to understand why combination therapy is essential and why during recent years multiple drug-resistant strains have emerged. So there are factors to consider in selecting the appropriate anti-tubercular therapy. So follow me as you look at this table. The growth rate, which is dependent on the oxygen tension and pH, and the particular site where the organisms are located, is a very important factor. The most actively growing cells are located in the pulmonary cavity, where the cells are well oxygenated and the organisms are actively dividing and the easiest to eradicate. INH, streptomycin, rifampin, or ethambutol are best defenses against this group of cells. But there are also organisms in macrophages and in caseous lesions where the growth rate is decreased because of low pH. Eradicating cells requires extended periods to compensate for the lack of metabolizing targets. These cells inside macrophages are best treated with pyrazinamide, INH, rifampin, and ethambutol, while those in caseous lesions are targeted by rifampin and INH. So the first-line drugs include INH, rifampin, streptomycin, and ethambutol. Pyrazinamide is added as a second stringer. Because the mutation rate for resistance in this organism is extremely high, it is imperative that all target cells in all locations are reached at the same time. The mode of action of each anti-tubercular drug is therefore considered when combination therapy is provided. The last portion of this lesson will review briefly other mycobacterial species and the infections that they produce. Infections caused by non-tuberculous mycobacteria have increased during the past decades. The major contributing factor to this increased incidence is HIV/AIDS epidemic. Other risk factors are underlying immunosuppression due to chemotherapy, instrumentation, chronic pulmonary disease, or percutaneous trauma. Some of those commonly encountered among these patients include Mycobacterium avium complex, or MAC, usually associated with HIV/AIDS infected patients, Mycobacterium gansacei, Mycobacterium marinum in wound infections contaminated with water sources, Mycobacterium scrofulaceum, Mycobacterium fortuitum, and Mycobacterium chelonia are associated with percutaneous trauma and instrumentation. Um, Although the majority of the non-tuberculous mycobacteria are isolated from pulmonary samples, other areas may also be involved. The lymph nodes, skin, and soft tissue, gastric aspirates, urine, CSF, bone marrow samples may be submitted for studies. Disseminated infections among AIDS patients, as I mentioned earlier, involve the MAC or the Mycobacterium complex, which are isolated from both feces and the blood. Because some of these non-tuberculous mycobacteria are common in nature, they may be found in soil, water, sewage, or even raw milk, and some are members of the human microbial flora. It is often difficult to interpret their clinical significance when isolated. So you have to determine whether this colonization or contamination exists. It is important because most of these species are multi-drug resistant. So there are certain criteria that may guide you to determine the clinical significance of these species when they are recovered. For example, the presence of clinical evidence, clinical symptoms and history of the patient, the results of clinical evaluation, such as X-ray and other methods, clinical findings, repeated isolation of the same organism from different samples at different sites and different times, isolation of these organisms from a sterile site, such as sterile body fluids, so these are maybe your guiding, some guiding criteria and some guiding principles that you may use in evaluating the clinical significance when you isolate non-tuberculous mycobacterial species, particularly this species listed here. So lastly, here are some points to remember. We did not talk about biosafety precautions in the laboratory. That goes without saying. Remember the clinical presentation of affected individuals, the clinical findings and the symptoms, where the sample were collected, the infections caused by non-tuberculous mycobacteria. Remember the characteristic features of Mycobacterium tuberculosis and the specific features of other non-tuberculous mycobacteria. Do review the processing and decontamination procedures and the reagents used to process respiratory samples, particularly sputum samples, and others such as urine and those contaminated with Pseudomonas aeruginosa in particular, and other isolation and identification processes such as the specialized media used to recover mycobacterial species. This is the end of this presentation.